the problem with how mothers and women think about birth is you want it to be perfect. You don't want to think about outcomes. You don't want to think about what could go wrong. You want a fairy tale birth because it is so tied up as it is your first step in a motherhood journey, and you want that baby. You want to give it everything. It's the start of wanting for it to just be happy, go to the best school, have the best start, have the most friends, you just want it to be perfect.
Do you think a perfect birth exists? Is it possible?
A perfect birth is not what any of us should be aiming for.
Mm-hmm.
We should all be aiming for the best birth that we can, given our circumstances.
Hi and welcome to the Women's Handbook podcast, How to Be a Woman, where we discuss everything women's health from menarche to matriarchy. I'm your host, Dr. Natalie Hutchins, and today we are talking about an evocative subject in women's health, how to give birth. Now, this topic can be pretty polarising, and I think for any woman who's having her first baby, I think navigating the varying opinions can be a bit of a minefield. So I'm here in London. It's a bit of a different look for the studio today. We are talking to my very good friend, Dr. Lucy Lord. She is an obstetrician over 40 years. She has delivered over 6,000 babies. And I think that if there's anyone to get tips from on how to give birth, it is her. So here we are. Let's get started. Hi, Lucy. How are you?
I am very well, thank you.
Thank you so much for coming in and agreeing to do the podcast with me.
No, I always know it's going to be good fun talking to you.
Of course, it always will be. Now, I want to get straight into it. I want to talk to you about the clinic and, your move from Hong Kong. But I do want to just start off with talking about, what most women want out of their birth. Because I think whether you're in the unmedicated vaginal birth camp or you're in the give me a straight elective caesarean camp, ultimately, the outcome that most women want is that they want to feel respected, that their wishes have been heard, that they've been listened to, that they feel empowered, that they get a healthy baby at the end of it, but they also emerge unscathed by birth trauma. Do you think?
For 99.9% of women, I would say what they want is to complete their family with the best baby they are able to give birth to in that pregnancy, with the minimum of damage physically or psychologically.
Absolutely.
Firstly to themselves, but secondly to the rest of their family and people they care for.
Okay.
And there is no exception to that.
No.
But interestingly, no one normally in the NHS, when you're looking at taking appendicitis, managing renal failure, we have a clear outcome that we're aiming for. But everyone is so terrified of treading on choices and things. Even the Royal College doesn't go, we are all agreed, mums, midwives, obstetricians, administrators, whoever, this is what we're aiming for.
Yeah.
And how can you possibly judge a system for helping with birth unless everyone is aligned in where you're going?
Yeah.
So I think that's why it's important. This is a gold standard, and it should be a gold standard.
But isn't the problem that the outcome or the ultimate outcome is the gold standard, but it's the way that people get to the outcome, and that's incredibly varied. So for one woman, it could be she wants to birth in one way and another in a completely different way. And in a system like the NHS, you've got to accommodate all of those preferences.
No, I absolutely don't agree with that.
Okay.
So if you listen to conversations that women are having about birth, they are not about outcome.
Okay.
But they are discussing it as if in its own right, it is an outcome.
Yes.
So women go, when you say, what do you want out of your birth? They go, I want a home birth, or I want a water birth, or, I want to make sure that I'm in this unit or that hospital, or, I want Evian, not San Pellegrino, So choice is highlighted as an outcome.
And do you think then that women are focusing on in the wrong thing, that they're focusing on the process rather than on the outcome?
They should start with the outcome, because obviously you cannot determine a process until you know what you're aiming at. Now, I think hopefully unintentionally, but the government in the UK particularly hasn't been able to deliver outcome. So what it has championed is choice.
Yeah.
Now, if you can't guarantee outcome, choice becomes irrelevant. So the least we should do is be honest with our women and go, this is the outcome everyone wants.
Yeah.
And now let's see what choices we can build into that to make you feel in control.
Is there an ideal world that exists where that woman can have the outcome and the choice? Is it that, okay, if she goes private, yeah, she can have everything that she wants. She can have the outcome and she can have all the choices. Or do you just feel that birth is inherently something that's slightly out of our control, and regardless, we have to focus on the outcome, and there will be women that are disappointed because they can't always have the choices that they want?
No, I think you can have the choices that you want if the systems are in place to make you understand the consequences of different choices. So I always say to my private patients, particularly usually my private patients are over 35, mostly career women, and of varying risk depending on their past histories. I always go to them, if you are 22, have a BMI of 18, are 5'10", and your husband's 5'11", you're fit, you're healthy, and your pregnancy is progressed normally, go and give birth on a bus. It does not matter, right? Likely your baby will drop out.
Yeah.
The risk of anything going wrong with that pregnancy is incredibly small.
Right.
So that's basically your
supermodel,
your classic supermodel.
Yeah.
You know, the Heidi Klum.
Yeah.
And a terrible poster child for most women. And social media is terrible because all celebrities, first of all, go, oh yeah, I got to 43 and then I just thought I'd have a baby.
Yeah.
And they don't own up to the fact they've spent, $200,000 on the IVF, the egg freezing, the egg donation, and people go, oh, maybe I'll just wait till I'm 40. I could do that. I'll wait till I'm 43 and then I'll pop a baby out.
Yeah.
No.
Yeah.
And equally, they do things like, oh, I don't understand. It was so lovely. I decided to give birth in my swimming pool in California.
Yeah.
And the baby just popped out. My husband taught it to swim and then we all swam to the side and it was lovely.
Do you know who Vic Hope is? Have you seen those pictures recently of Vic Hope?
No.
She's from the Beautiful Woman Brigade. She's got this beautiful mansion in Ibiza and she recently had a home birth on her balcony looking out over these beautiful hills. And even I, who am a hospital birther, was like, oh, yeah, maybe I should do that in my next life. Yes, they do make it very, very glamorous, certainly.
Yeah. No, and I think it's so the problem with our how mothers and women think about birth is you want it to be perfect.
Yeah.
You don't want to think about outcomes. You don't want to think about what could go wrong. You want a fairy tale birth because it is so tied up as it is your first step in a motherhood journey and you want that baby. You want to give it everything. It's the start of wanting for it to just be happy, go to the best school, have the best start, have the most friends, you just want it to be perfect.
Do you think a perfect birth exists? Is it possible?
A perfect birth is not what any of us should be aiming for. We should all be aiming for the best birth that we can, given our circumstances.
Yeah.
Let's not compare what we can do with what a 6-foot supermodel, billionaire can manage on their balcony.
Yeah.
Like, just don't even go there.
Yeah. And is it also, the idea of a perfect birth, it's also about expectations, isn't it? Because I feel like with my first child, I had a perfect birth for me, in terms of what I expected. I stayed at home until I was 5 centimetres with a TENS machine, bit of hypnobirthing, went in, had an epidural. She was born 2 hours later, minimal perineal damage. And for me, that was my perfect birth. That is what I wanted. And those were my expectations were met. So do you feel that in some ways having a perfect birth depends on what you're expecting? And if that is the case, then surely our counselling of women, a bit like what we're doing today, needs to be better so that they expect what's realistic and not what they see on social media.
Yeah. So going back to, I'm giving you advice, this is the quick version, not my 7 months of getting to know you as a private patient. This is whatever you've got to navigate, whether it's the NHS, whether it's private, whether it's a home birth, what are your outcomes? So we go back to outcomes. I would be very surprised if anyone writes anything different from, I don't want a baby that's brain damaged. I don't want a baby that doesn't survive. I don't want a baby, ideally, that ends up in NICU. I don't want anything to happen that stops me having my next baby because I want 2 or I want 3. And I don't want the birth to be so traumatic that my risk of postnatal depression is such that I'm going to have trouble bonding and getting through the next 6 months. Because let's be clear, I would always say to my private patients, because after you've done a lot of deliveries, so when I started in private 35 years ago, I'd already delivered 2,000 babies. So if at that point you're pretty sure, absent the obstetric equivalent of some kind of typhoon hitting, physically you're going to manage it. I would pretty much be able to guarantee that my patient would get a healthy baby, or if it was going to be healthy before it was born, it would be healthy after I'd birthed it.
Got it.
Absent, small risks of prematurity, and just out of the blue typhoon-like things hitting that no one could have predicted. So in private, your main thing is, can I get my patient through this birth with the best mental health she can have?
Right.
And there are ways of doing that, mostly based on that very close personal relationship you develop in private and sense of trust and understanding. Now, not everyone can afford private. So if you can't, how do you navigate everything else?
Also, when you're not seeing the same person every time, you're seeing lots of different people. It's quite difficult to get that relationship.
You need to have a theme of trust, and to do that, you need to do some research and due diligence. Also, although private is out of the vast majority of people's affordability, sometimes one appointment is not.
Right.
If you are high risk, if you're really concerned and you're worried about navigating a public system, get to 36 weeks and have one appointment with a private obstetrician. And talk it through with them. Because you will have a very experienced person focusing on those particular problems. So, I mean, we've probably in that taken care of maybe 10% or 20% of people in the NHS public sector, i.e. not your normal private
Yeah.
Maybe 20% of them could afford to go and see someone and get
Just
some
once.
very personalised advice.
Because we're not talking about a Chanel handbag. Because that's
No,
not how
we're
much
not
it costs.
even talking about a Chanel handbag. We're talking about a normal handbag.
A normal handbag.
Yeah, normal handbag.
Got it.
Give up the normal handbag for Christmas.
Yeah.
If you're really concerned because the NHS has been in a bad way, spend it on research your private obstetrician. Make sure they've got the time and the experience in your problem.
Yeah.
It may even be an obstetrician that works in the NHS hospital where you work. And then they can also have access to your notes.
That's a really good idea. And what gestation would you see them at?
36 weeks.
36 weeks.
If you get, before that, usually there's not, the birth will be what it will be because you've gone into labour early. And they, the NHS will have done their, they'll have run in and sorted it out.
Yeah.
If you think you've got something that increases your risk of premature labour, go at 16 weeks if you can afford it.
Okay.
But if you think you're a normal bog standard but have concerns about things that went wrong in the family or your age or something that's going to put you at 36 weeks and a bit worried, it's a good way to spend 300 quid.
Yeah.
And actually, I mean, sometimes in the NHS private sector, it's less than that. It's really worth it. Okay, not everyone can afford that.
Yeah.
So the next bit is prep.
Okay.
Right? Before you get pregnant.
Right.
Prep.
Yeah. Yeah.
And there is lots that you can do. So to focus people on risk stratification, which is the most important thing you do as a private obstetrician for your obstetric patients.
Yeah.
Not with rose-tinted spectacles. You go, what is the thing? What are the things that are going to mess with this patient?
Yeah. And what types of things are we looking at?
So the things that you could, starting with the things that you can do something about, i.e. not your genetics or, those kind of things, but things you can do something about. So weight.
Big one.
Number one thing.
Yeah.
People with BMIs of under 25 do so much better.
Yeah.
You can't do much about age, but be clear. If you wait to 39 to have your first baby, it is, unless you're the aforesaid supermodel, it's not going to drop out.
Okay.
You need a different strategy.
And what is it about age that, is it the uterus contracting? What is it about age that leads to increased intervention or poorer outcomes?
We were meant to give birth at 16, 17, 18 with our first birth.
Yeah.
I am pretty sure, although it's so long ago when I looked at it, from cervical biopsies, if you look at biopsying cervix, and I am, please forgive me, making the numbers up, but basically your cervix is made up of elastin and fibrin. Elastin is like your spandex. Fibrin is like your cotton.
Yeah.
And when you go and buy that thing, it says 5% spandex, 100% cotton.
Yeah.
That's partly because spandex is really expensive.
Right.
Compared with cotton. And elastin for your body to make is really expensive compared with fibrin. Fibrin's any old cotton.
Yep. Got it.
So imagine, 200,000 years ago, or no, imagine 200 years ago, the only women who got to 40 without a baby were in a nunnery.
Right, yeah.
And the only time they got pregnant for the first time at 40 is when whoever raped and pillaged the nunnery.
Got it.
Right. So everybody got pregnant early. And when you give birth, the cervix goes, oh, woohoo, you know, God, giving birth, that was a bit, woo, and, we only just made it.
Yeah.
And thank God we were 16 because we were 90%, our cervix was 90% elastin waiting to give birth and 10% fibrin. And God, we better keep making that elastin because we want the next baby to drop out and the cervix to be super stretchy.
Got it.
Like getting, your spandex thing over your head and everything.
Yeah.
If you wait till you're 40 to have your first baby, the body's gone, well, bloody hell, she's in a nunnery. She's not going to get pregnant, or she's infertile, or that, you know, or no one's shagging her for whatever reason.
Forget the elastin.
Let's not spend all that money on elastin.
Got it.
Let's just finish off the cervix with the fibrin.
Right.
So you're then 90% fibrin. And you take probably, you know, I don't know, but a lot more contractions to dilate that cervix.
Got it. That makes sense.
And then you've also, you know, there's all that muscle in your uterus. Muscle's more expensive. It's less expensive than elastin, but it's a lot more expensive than fibrin. So you've put quite a lot of fibre and stuff down in you. So you don't contract as well.
Okay.
So just, your body's gone. She's not pregnant by the time she's 35. She's probably not going to get pregnant. I'm not closing it.
Yeah.
But I'm shutting it down.
I'm becoming more efficient for your body.
Yeah.
Yeah, for what your body needs.
Yeah. When I was trying to engage in private with people having a very unrealistic expectation of a 4-hour labour and 2 pushes and being 43 with their first baby, I would go through a process where we looked at all risk factors.
Okay.
So someone with is 43 with a BMI of 20 is going to do a lot better than someone who's 43 with a BMI of 40.
Yeah.
In fact, because it was Hong Kong, Chinese have a thing about the number 4 because it means death.
Yeah.
So in order to engage and be relatively cross-cultural, I would say to women, what you need to watch out for is all the 4s. And for every 4, i.e. the things that have 4 in them that are bad, which was things that that were clear before they got pregnant and things that became apparent during pregnancy, I would increase their risk of a difficult labour and caesarean by 10%.
Okay.
So, for example, for a woman who was 43, had a BMI of over 30, whose baby was measuring 4.6 kilos, where the head was 4/5 palpable, they'd gone to 41 weeks, their Bishop score was less than 4, we would get to the point where their risk of a caesarean section was genuinely 90%.
Okay.
And I would try to say, I can give you a fairly accurate view of what your risk is during labour of it being difficult and potentially ending up with a C-section.
Yeah.
But it's your call at what level you want to bail and have an elective section.
Yeah.
But at least you know where you are and your expectations have been fully managed. And so the worst thing is that your belief that a birth is going to go in a particular direction and then the shock that it doesn't.
Just to hone in again on the age point of view, because I think there will be a lot of women listening who are probably having their first baby over 40. You're saying that essentially with your rule of 4s that it's a cumulative effect. It's not purely about the age, but it's about what comes with it.
It's a cumulative risk.
Yeah.
I would say there are 5 to 10 important factors that you can score yourself on that will give you a reasonably accurate guide of
we should make a calculator.
To brought a calculator.
Yeah, no, as in we should make a risk calculator.
I've done a risk calculator.
Yeah, that's amazing.
There's a range. So you get points. I'll send it to you. I'll send it to you. We'll refine it. Yeah. You and I'll work on it. We'll put it on. It's about 2 weeks away from going on our website at Central Health.
Amazing.
And it is
really helpful.
It is really helpful.
That is really helpful. Yeah.
Because actually the problem with the way choice is couched in the NHS, it's encouraging women to choose to be low risk.
Yes.
And you cannot choose to be low risk.
Absolutely.
You either are low risk or you're not. So first of all, you're given the full NHS smorgasbord buffet of how would you like to give birth?
Yeah.
Including home births.
Yeah.
Well, I'm sorry, but if you're diabetic, have a BMI of 45 and a 43, home birth's not appropriate.
Right.
And the problem is when I think midwives quite rightly are gently trying to encourage women who are unsuitable from having a home birth, it's or an obstetrician or anyone, it's not viewed in a good light. It's like I'm being discriminated against. It's my right to choose to give birth at home.
Yes.
Whereas if you go, have a look at this risk scoring, think about it.
Yeah.
Do you really want to take this kind of risk?
Yeah.
So for those people who you can pretty much know have got, and it's always a range, maybe 70 to 90% of a difficult birth and a difficult delivery, you do want them to engage with where is the safest place for me to do this.
Yes. And I want to come back onto that in terms of place of birth, because what I really wanted to do was make this podcast episode quite practical. So we can't do it for every scenario. We can't do it for every woman. But thinking about not that woman with the high BMI, but the woman with, BMI of 20, she's low risk, she's fit and well. She doesn't have any complications. She's done all her antenatal care. She's been absolutely fine. So if we're thinking about her birth plan and the choices that she might make and put on that birth plan, and we're thinking firstly about place of birth, home versus hospital, can we try and think about the evidence and what it shows in her position that might help her guide her decision? Because if you look at the data over the last 100 years, whatever, I mean, there's been a massive shift from home to hospital birth. I mean, I think it was like, the majority, 85% of women in the 30s would give birth at home. And now I think it's about 2.5%. And of course, alongside that, we've seen a drastic reduction in perinatal mortality.
Yeah, and maternal mortality.
And maternal mortality.
I mean, if you think maternal mortality was about 1 in 100, 1 in 200 prior to the 1930s. So things changed in 1935 with the advent of antibiotics.
Yes.
That revolutionised.
Yeah.
And if you ever Google maternal mortality, you'll see it drop off a cliff in terms of risk at the same time that sulfonamides were introduced.
Yeah.
And that was because cesarean section and interventions that were necessary. So that's changed. So the maternal death rate, I always get it was about 1 in 100, 1 in 200. Prior to antibiotics, it hadn't changed much, probably for 200,000 years. And it is now about, I always get it 1 in 10,000. Is that right? Or 0.8 in 10,000.
Yeah.
And, that's an amazing, imagine the devastation of a family losing a mother, often first baby, because they were still the most dangerous. So I think it's we've made it so much safer.
We have.
But out of the blue, it's never 100%.
Yes.
So in terms of, and home births, there was the research on home birth, which it concluded that home births were safe.
Yeah.
For second-time mothers, if you look at the figures.
Okay.
If you'd successfully given birth the first time, the second, and you were low risk, it is probably reasonable that you could choose a home birth. If you actually look at the numbers, and nobody really wanted to say it, there was a significant increased risk for the babies and the mother if they attempted birth at home.
If they were a first-time mum.
If they were a first-time mum.
Right. And that's because you can't adequately risk stratify someone who's actually never been through the birth. It's an unknown risk. She's not a low risk. Is that right?
No. You can stratify for a first birth and you can put everything together. But however, that stratification for a first birth is completely overturned by a successful vaginal delivery.
Right.
So if I had someone who was who'd got everything against them, they got a BMI of 35, They were diabetic. No, sorry, not diabetic. They got a BMI of 35. They were older. If they'd had a normal delivery 2 years ago, I would completely negate. I wouldn't do the calculation.
Yeah.
Because
they proved themselves.
Yeah, basically a previous uncomplicated normal delivery, particularly with a short second stage, which is the absolute indicator of the capacity of your pelvis. Basically, if you give 2 pushes and your baby drops out, so long as you don't have a baby
that's huge,
double the size of your last one, your birth is almost certainly going to go smoothly. The stratification is just trumped by your birth history.
Yes.
There's no point doing 4s or anything like that for a second baby. You just go, what happened in the first delivery? If it's a normal birth, then you don't have to worry about it. You do redo it for the second delivery where the first delivery was a C-section. Because you have, as the old obstetricians used to say, an untried pelvis, or
an untested,
either an untried one because you had an elective section, or an unsuccessful pelvis.
Always can't be unsuccessful. They haven't tried.
No, because they could have had emergency C-section,
right?
Having got to 9 centimeters and not
got it.
So you learn from the first delivery. It's either as you would say, a perfect birth, or you had a normal delivery. You didn't have a forceps. You didn't have a terrible perineum. You know, and that guides you absolutely. So long as your baby's head down, a similar size, it's not unreasonable to go and have a home birth.
Okay.
My problem with all of this is that certainly when you're an obstetrician and you have worked in high-risk units, we all know that with all the planning, the risk management, the stratification in the world, occasionally you get that typhoon that hits that shouldn't hit.
Absolutely.
And all bets are off. So I always say to people, if you are very strategic, very low anxiety, not a kind of guilt, blame person, you can take more risk. But in the context of childbirth, if you have taken more risk and the typhoon hits and your baby dies, or worse still, ends up with brain damage, can you live with yourself going forward? Now, that is a very, very difficult question. And it's so difficult that most women don't ask themselves that question. And I think I've forgotten who it is now, but we're there looking at it with that very sad case of the freebirther. Whose baby, who had a stillbirth. So looking at that, she had risk. If she was unlucky because she'd had 2 vaginal deliveries.
Right. So actually she was a candidate.
She was a candidate for a
home birth,
supervised home birth. But as a private obstetrician, if she had been with me, I would have gone, you're 39 and you're 41 weeks. That carries a risk of stillbirth. Do we really want to do that? So none of my patients, I wouldn't have been comfortable remaining silent with a 39-year-old patient. At 40 weeks, I would have said, if we want to avoid the significant, for me, but given I'm a perfectionist, and I think most women are when it comes to that question, I would induce.
Okay.
And it doesn't matter how many babies you've had before, because it's still an increased risk. Even if you've had 6 normal deliveries, if you're close to 40 and you're over 40 weeks, it's absolute perfect storm of unnecessary risk, which I think is the worst kind of risk.
Absolutely. Just bringing it back to our, you know, our low risk woman, first baby, playing devil's advocate about what you've said about home birth, there will be people, like you say, who say, well, actually, that massive drop in perinatal mortality and maternal mortality, like you say, wasn't necessarily due to the massive swing from home to hospital birth. It was because of the advent of antibiotics and incubators and blood transfusions and better anaesthetics and all those other things that came along with it. And therefore, if you've got an integrated system where you've got well-trained midwives who are able to spot when things are going wrong and you're able to transfer that woman, she's selected appropriately, so she's risk stratified and she is low risk, and she's got all those things and she's able to be transferred if she needs it and get access to all the things that she needs. Have we just swung too far towards hospital birth? Could it be safe in that scenario?
That moves on to a different risk stratification process, doesn't it? So what you then have to risk stratify is what is the ability of my NHS hospital and my home birthing midwifery team to manage that.
Yeah.
And the NHS is under incredible strain. And we've all seen, you know, the rise in traumatic births and all the, you know.
Yeah.
So I would say to you, yes, in an ideal world, if we were presented again with a perfect integrated home birth NHS system, then the risk might be acceptable. I think no one knows now, because the NHS is in freefall.
Yeah.
It is not, I would say it's now not just dysfunctional, it is decompensating. So we've been in a long period where very, very good people who've dedicated their lives to the NHS because they believe in it. Doctors, midwives, nurses, obstetricians, even some administrators. And we're now getting to the point when those very competent and very resilient people are in an environment that is so bad that even they are bailing. And obviously, when I came back from Hong Kong, I had this view of the NHS that I left in 1989.
Yeah.
And I was like, great, I'm going to have such fun. I'm going to go and I'm just going to do pro bono because obviously having spent so long in private, I didn't need the money. I'm going to do a day. I'm going to be really nice to the NHS and I'm going to do a day in the NHS. I'm just going to do a cesarean list because, you know, it's what I know how to do well. And it was not the NHS I'd left.
Yeah.
Most importantly, the morale is so broken. Obstetricians and lots of doctors are just looking for ways to leave. And I don't think I'm speaking out of turn because everybody knows that. Whilst going into medicine is still hugely popular, staying in a career in medicine is not only not possible, it's not what people want, it's almost not possible.
Yeah.
The degree of resilience required to cope with the huge hurdles to good care. And the people in the NHS who are suffering the most are the people who care the most.
Absolutely.
If you are able to sit there and go, oh yeah, like we're understaffed, the ceiling's falling down, we haven't got this equipment.
Yeah.
My daughter works in A&E and often comes back home and goes, I didn't have a chair all day. There wasn't a chair for me to sit on.
Unbelievable.
There wasn't a computer for me to work at.
Yeah.
And she loves the NHS. She really cares about it. And I'm worried. I think she will get through 10 years because she's so committed.
Yeah.
And she's lucky in many ways that, you know, she's got lots of other things that support her. But basically, we are now looking at most doctors, I think, are going to be leaving.
Yeah.
Even if they commit to the NHS, they're going to be leaving at 50, 55.
Do you think you would have had the longevity in your career had you stayed in the NHS? Do you think you would have had the same?
No, I think I'd have been
passion and love
spat
for it?
out, actually, because I'm, you know, a disruptor and a maverick. And the NHS doesn't cope well with that.
Yeah.
So probably I would have been spat out at some point for... Yeah. I also have a huge... I align myself as a mother and a woman with the patients. And I think I would find it completely impossible to work in an NHS system that is so where it so fails the patient in so many ways.
Yeah, and it fails its doctors as well, as you.
Yeah, it fails its doctors, it fails its staff. It's a juggernaut, and I think the politicians are hugely hypocritical. They know that the current system is unsustainable. Yeah, and they won't bite the bullet on the belief that they would be unelectable. Yeah, if they suggested that we could no longer provide it free at the point of service, at the point of service for everybody.
Bringing it back to home birth, hospital birth, then I think you're saying in an ideal world, yes, that woman who is first-time mum, completely low risk, fit and well, could be safe at home if you've got a perfect healthcare system.
And you can live with the risk. Because when things go wrong, people then research deeply. Yes. And what will come up with your first birth is there was a tiny increased risk from you choosing a home birth. Yeah. 99 times out of 100, that does not matter. Yeah. But if things go wrong, can you live with that? Yeah. And unless the answer is yes,
don't do it.
Don't do it. Yeah. Yeah.
Yeah. What do you think is going on in women's minds who choose free pregnancy, free birthing, you know, no antenatal care, no birth attendant, no scan, nothing? What is that about? I mean, it strikes me as being, you know, the birthing equivalent of going to live off grid or something like that. You know, the modern world has become so overstimulating, overwhelming, and your only way to control it into being full control is to completely disengage with it. That's how I read it. I find it just so, and maybe it's because we know what we know, we've seen what we've seen, but and when you have those unknown unknowns and you don't know, it's easier to go there. I just find it, slightly sad that if it's a reflection of kind of mistrust between doctors and patients, that we've got to the position that women are choosing to birth completely on their own. I just find that...
you look at birth, you do not want to engage with an incredibly complicated system, which we've just been talking about how you protect that baby. So how do you engage in a complicated risk stratification? You're risk stratifying your own risk, you're risk stratifying the risk of the provider, you're looking at your family. It's overwhelming. So navigating childbirth, the complexity of the emotions and the options, and so I think these women just opt out. Yeah. They can't engage. And it's usually because they have had trauma. And it pushes them over the edge. And to be quite honest, for most women, it is tempting not to look at not to do what I've told everyone to do. Yeah. It's tempting not to look at outcome.
Just to ignore it. Yeah, absolutely.
It's tempting to look at, should I have Evian or should I have San Pellegrino? Yeah. Should I give birth in the midwifery unit or in the, low risk unit? You know, it's tempting to not look at the iceberg, but to rearrange the deck chairs
100%,
on the
yeah.
Titanic and choose what music you would like to have playing.
Yeah.
Yeah.
It's just too much.
It's too much.
Yeah.
And it's so tempting to go either with opting out.
Mm-hmm.
It feels better.
Mm.
You don't have to look at it.
Yeah.
Or to have a magic bullet.
Yeah.
Everything will be all right because I've got my own TENS machine.
Yeah.
Or,
and I'm in control.
Yes, everything will be all right because I've taken raspberry leaf tea.
Yeah.
Everything will be all right because I've got my doula with me.
Yeah.
Everything, so have a magic bullet.
Yeah.
Rather than engage with a hugely difficult and complex problem.
Yeah. Yeah.
And it's a shame because women now feel they have to manage it themselves because we've lost confidence in all of the NHS for some, in some places with very good reason. Mm-hmm. But this has not made things better.
No.
So I fully understand the urge to opt out, but it's not a good decision.
No.
You wouldn't, it's difficult and complex to manage your finances. But, as we know over and over again, choosing crypto or opting out, to a financial advisor in Cyprus, it's never a good
idea.
It's never a good magic bullet.
Yeah.
If you want to reduce risk, you have to engage with the systems and the people available to you.
Do you think we've caused it by driving kind of this over-medicalisation, as it were, of the birthing process? Is it our fault as medics?
No, it is not our fault. What we've taken is a birthing process designed by evolution to meet the needs of the survival of the race. Mm-hmm. And for that, it was for the majority of births to result in able-bodied individuals who could fight wars, resist famine, and give birth.
Yeah.
We have to be very clear that the evolution of the birthing process was not there to meet the hopes and aspirations of individual women. Mm-hmm. We would get nowhere to say, tell you what, let's go back to natural birth, have 15 babies at home, 2 of them will die, but you know what, you got like 13, you're up on the deal.
Yeah,
That is not where we are.
No.
Right. Okay. So what we have done, the medical profession, is we have genuinely tried to meet the hopes and aspirations of women now, which is very much you are only as well or as happy as your least well and your least happy child.
Absolutely.
Right.
Yeah.
So we are trying to manage that for our women. And it is not just, don't worry if you lose a few, darling.
Yeah.
It's going to be okay because you've got,
got
you're
the
up on the
experience you
deal.
wanted. Yeah.
Yeah. We are not up on the deal if we've had any stillbirth or any harm come to our babies. So if you take that, actually you would go to hospital.
Yeah.
Yeah?
Yeah.
And our assumption as obstetricians, particularly as mothers and obstetricians, is I know I could not live with myself if an action I took, because I have double responsibility.
Yeah.
I am that baby's mother and I am that baby's nearest obstetrician. I could not live with any harm coming to my babies because of decisions I have made in pregnancy.
Yeah. Yeah.
And I can share that with you because I did make a mistake in pregnancy.
Right.
Well, for which I tortured myself about 4 years.
Right.
I had hyperemesis, you know, way off the scale from most hyperemesis.
Like really bad.
Like, so when I accidentally got pregnant, I was 61 kilos. By 20 weeks, I was 43 kilos.
Jeez.
If I stayed completely still and did not move my head for those 20 weeks, I would vomit 14 or 16 times a day.
Gosh.
If I had to get up and about and move my head, I would vomit every 3 minutes.
Completely miserable.
Absolutely crap. And the first time, you know, we didn't have much. We didn't have good drugs. But honestly, I took everything we had.
Yeah. Yeah.
The second, and then it took me 7 years to have a baby.
Right.
And I took steroids in early pregnancy. And because that actually does work. It's really good. And I researched the hell out of, you know, is this going to be a problem? Is it not? And then my son was born.
Yeah.
By the way, girls are really great and boys are a nightmare. Sorry, James, if don't listen to this podcast. Okay. For the first 2 years, James did not speak.
Right.
And I went into a spiral of despair that it was because of the steroids.
Yeah.
And who knows?
Yeah.
Right. But I can absolutely say it is such a primitive thing.
Yeah. And we do it for everything. I mean, not even things as serious as that. You know, anything that we do with regard to our children is a source of never-ending guilt, isn't it?
Yes. And also, I have to say, as an obstetrician, I then struggled being an obstetrician because I'd sit there with my unspeaking 2-year-old.
Yes.
He's still a pain in the ass, but he's very lovely now.
And very successful now.
And you know, went to King's, got a good 2-1, still drives me completely potty. But there is no bottom to that guilt bucket.
Yeah.
And what was interesting is I would things that I'd never worried about before. So this must have been 2000 after I had James. Women had come in and go, oh my God, I forgot my folic acid yesterday. Like, you know, and you go, oh my God, I took steroids and this person is worried about their folic acid.
Yeah, yeah.
So it's so primitive.
It is.
You so want that perfect birth.
Yeah.
That I forgive women any amount of madness because all they're trying to do is get a perfect birth.
Absolutely. And they know that if they don't,
no
matter what you've done,
there's
it
no
is
bottom
your
to
fault.
you know, and the silliest things, you know, like, oh my God, you know, I didn't realise I was pregnant and I had half a glass of champagne.
Yeah.
You know, I didn't realise I was pregnant. I had a massage. I didn't realise it is never ending.
Yeah.
So the fact that you choose what an obstetrician, you know, probably a male obstetrician, sorry boys, but you know, you don't, a lot of the time, you don't get it.
Yeah.
You know, you don't get the guilt bucket. Would go, what the hell were they thinking? A free birth. You know, what is going on?
Yeah, yeah.
I forgive women any amount of madness because they are just trying to manage their guilt. Yeah. And it's unmanageable.
If you told that, so if that woman was in clinic, you know, she wasn't having a free pregnancy, but she wanted a free birth and she'd come to see you and you were trying to talk to her about that possibility, the only way to do that is almost kind of not to scare her, but to make her aware of the risks. How do you do that without someone then going, oh, no, you're just scaremongering. You're just trying to, you know, get me to do something I don't want. That's, you know, you're taking away my agency. That's not what I want to do. How would you kind of approach that patient?
I think one of the reasons, and again, I love kind of, I'm a complete evolutionary anthropology amateur, but you look at observed behaviour, and it nearly always in motherhood-related matters comes back to evolution.
Yeah.
And one of the things all mothers need to believe is they have efficacy and agency in protecting their children.
Yeah.
If they don't believe that, so you see that all the time. There's all the things about the mothers lifting the car off to the toddler.
Yeah.
Yeah?
Yeah.
And mothers doing extraordinary acts of bravery and stupidity to protect their children, you know, running in front of cars, whatever it is.
We would do anything.
Because one of the remnants for needing to believe that you could make a difference as a mother. Suppose you really wanted to help your child, obviously, because you're its mother.
Yeah.
But you believe that actually there's not much you can do. So you might as well just sit on your bottom and watch it getting eaten by a saber-toothed tiger.
Yeah.
The urge to protect has to be matched by the belief of your agency and efficacy and your control over that outcome.
Yeah. You've got to believe that you can do it.
You've got to believe that what you do will mean that that baby survives. Otherwise, you would spend your time not running in front of the car, not tackling the lion. And we needed to, you know, because that's the extreme version, but everything, all the little things, we had to run and do it.
Yeah.
So what all women have is an overdeveloped sense of their ability to control what happens in labor. And and that's also something you need to learn as an obstetrician. I can control 99% of things in my framework, in my hospital, in my clinic, because I've done it 6,000 times before.
Yeah.
What I cannot control is a woman who really wants to go and do something stupid.
Yeah.
And scaring the shit out of her is only going to make it worse.
Yeah.
Because what you are doing is making that saber-toothed tiger bigger. And then she needs to double down on believing that she can make a difference.
Yeah.
So you don't do that.
Yeah.
What you do, I think, is say 99% of the time, this is going to be fine. But again, just be okay if it goes wrong. If it goes wrong on the labour ward at Queen Charlotte's, you have 30 people in the queue of people to blame.
Yeah.
And that it doesn't make it better, but it does make it survivable.
Yeah.
If you go off on your own and do your own thing, the buck stops really with you.
Yeah.
You will always throw, try and blame everyone else or whatever. Or, as I suspect, the poor Freebirther who had the stillbirth will go into some rock solid denial. But that won't last.
Yeah.
Forever.
Yeah.
There will be a reconciling at some point. And most likely her family will suffer from that inability to forgive, to engage
herself
in a process of forgiveness and grief.
Yeah. Yeah.
So I would just like more people in the queue to blame.
Yeah. Quite.
I mean, it's still irrational and it's still wrong and they won't have meant it and they won't have done it on purpose.
Yeah.
But at least you're not at the head of that queue.
Yeah. Yeah.
Does that make sense?
Makes perfect sense. Yeah.
Yeah.
Okay. Let's move on to talking about how labour starts. So, again, woman, first time baby, low risk. Should she be waiting until spontaneous labour occurs?
Yes.
Or
if she's 22,
yeah.
wait. You will almost certainly,
Yeah.
at 22,
Yeah.
not go massively overdue.
Okay.
I mean, that's when we're talking about first-time mums, we are assuming the system has worked for you.
Yeah.
And that we've spotted if your baby's too small.
Yes. So that's
we've
all,
spotted
yes.
if your placenta's not working.
Yes.
We've spotted if you've got hypertension, and we've spotted if your water around your baby's dropped off. So
and none of those things are true.
Yeah. If we're going with you've got a free pass, or you've seen a private doctor at 36 weeks who's done the scan and got it all sorted.
Yeah.
Then you can wait.
And
your movements are good.
For how long? Because there is a faction of, society that would say, well, you don't need any, your body will do it when it's ready. And, 42-week wait.
You're not going to go over at that age, you're not going to go over 42 weeks.
Okay.
And if you do, there is something wrong.
Okay.
And you need to, and at that age, that young age, young women of a normal BMI with a normal pregnancy with no risk factors, they will almost certainly not go over 41 weeks.
Okay. And just set the scene for us. So why are we even talking about, going over 40, 41, 42 weeks? What is it about becoming closer to that level of post-term that causes risk, if
so we know that the risk of stillbirth and perinatal death, so not just even if you get your baby out
and it's alive
and things, there are post-birth complications that increase as you get post-mature.
Yeah.
And you think about it, because your placenta's, it's got an expiration date for its function.
Yeah.
Which is why pregnancies don't go on to 46 weeks.
Yeah.
I mean, they just don't.
Yeah.
So, it's a very small increased risk. The problem with it is, unlike inducing a baby at 37 weeks, it is an entirely unnecessary risk. Because that baby comes out anything from 38 weeks and 5 days, it's going to be better off than going to 41 or 42 weeks.
Okay.
I mean, perfect, absolutely perfect is 39 weeks.
Yeah.
And I always went, I'm aiming at delivering all my babies at 39 weeks would be perfect.
Yeah.
Depending on your age, I kind of want them out by 40 weeks and 3 days.
Yeah.
That is my sweet spot.
Yeah.
And you're paying me a lot of money to not to go good enough, but to hit perfection.
Exactly. So
not because perfection is good, but the closer you get to perfection, should the typhoon hit, you have no regrets.
Yeah, absolutely. And so at 39 weeks, you're saying that the rate of stillbirth, the rate of severe perinatal complications is at its lowest point.
Yes.
Before that, too premature. After
Before that, no. The risk is a little tiny change. Yeah. But what you're managing for is do the right thing for that baby
at the right time.
At the right time, but also do the right thing if the typhoon hits.
Yeah.
So if that baby, just has in private, you're going, I want that baby out, and the other things you're doing is, I don't want it to go to NICU because that's devastating for any mother.
Yeah,
it
that's
just
not
is.
the outcome.
It's not the outcome you want. In private, I am judged by getting the baby out, making sure it's healthy, but then there are lots of little icing on the cake. It comes out, has APGARs of 9 and 10. It doesn't go anywhere near NICU. It doesn't get jaundiced. It breastfeeds as well as it can. These are the San Pellegrino elements of private practice.
Yeah.
But getting it wrong, it doesn't affect the baby long term. It probably doesn't affect the mother long term. But it increases her risk of postnatal depression. Any tiny setback, because all our women are so sensitive, it's going to increase her risk of self-blame and postnatal depression. So my aim was, want all these things are a given, that I'm going to get this baby out. It's going to be, but I also want to be able to look myself in the mirror and say, I've done the best to make that woman's mental health as good as it can be.
Yeah.
And therefore I don't want any of this going to NICU.
So then if I'm coming to you as, you know, a low risk self and no antenatal problems, fit and well, are you going to induce me? Are you going to offer me an induction at 39 weeks based on what you've just said? And should, if I am that woman, should I be thinking in that way? So I am someone who, I agree with you, I don't want to take the risk, I don't want a home birth, I'm going to deliver in hospital. My main thing that's going to make me feel like I've got the perfect birth is reducing my risk to that baby as much as humanly possible. So should I be thinking about having an induction at 39 weeks?
So I'm a big, if it's not broken, don't fix it.
Okay.
So again, I'm not inducing Heidi Klum, age 22, at 39 weeks.
Yeah.
Or 40.
Yeah.
I'd let her go to 41.
Okay.
It's back to your risk stratification. And in the setting of, this is a mental health question. If a unmedicated vaginal birth is going to improve her mental health, I will do everything I can not to induce her and not to give her an epidural.
Got it.
Which means I would do everything I could to allow her to go into birth naturally. In private, I can manage that risk actively. So she would get daily CTGs, fetal movements, you know, Doppler, you know, all of the things that you can throw at things in private to reduce the risk that you are taking because you are trying to manage that woman's mental health. If it's in the NHS, you don't have that option. So I would make clear to my midwife what, again, if you want good care, be clear about what outcomes are important to you and state them from the start. And I think if more women stated what they really should be thinking about, which is, women, I think, don't state it because it's painful and because to them it's obvious. The assumption is they're choosing all these things as the icing on the cake to the fact that they will be getting a healthy, live, unbrain damaged, normal birth with minimum damage to their perineum. That's what they think is being delivered, or we did until we had all this debacle about trauma. If we pedal it back and say, and the midwives are then feeling that when you say, I want a home birth, that is an informed decision. That if you want an unmedicated birth and you're prepared to go 43 weeks, that is an informed decision. In fact, you've not wanted to look at the stillbirth risk, the brain damage risk, you know, the risk of forceps, the risk of, you know, all of those risks. You've blanked them out.
So it's an uninformed decision.
It's an uninformed decision. And somebody going through a checklist of, you understand that this, you understand that, it doesn't register because it's so, you cannot, alongside your hopes and aspirations for your first baby, look at the what ifs. What if my baby dies? What if my baby's brain damaged? What if what if I end up with a hysterectomy? You're not really going to look at that.
No.
A, because the risk is incredibly low, but B, because it's so traumatizing to look at that.
And also it's quite difficult to kind of conceptualize risk, particularly at those levels where it is very small.
It's very small.
It is pretty tricky.
But, you know, as we've seen, when you take the population as a whole and the narratives and the stories come out, we're then even more confused.
Absolutely. So what you're saying is if you've got risk factors, if you're older, all of the things that we've talked about, potentially you want to think about optimizing your risk and being induced at 39 weeks otherwise, or if it's really important for you to have that natural birth, you let it go on.
Yeah. And I think, obviously, educating all mothers to have a PhD in obstetrics is not where you are.
Yeah.
You can't always engage with my, rule of fours. If you're really interested, you've got the time, you want more control, you can go on our website and go, okay, I can calculate my own personal risk.
Yeah.
And have it's not, please don't report me to the Royal College of Obstetricians, but I think it's better than no idea.
I agree.
Yeah?
I agree.
But also have faith in the system, but work with it. So a lot of the things I used to do with women and people is to educate them how to interact with the system to get the best out of the system. So when you go to meet the midwife, even though it feels like a PhD in the bleeding obvious, go, the most important thing to me is the health of my baby.
Yeah.
I want my baby to have the best chance of APGARs of 9 and 10.
Yeah.
I want to be able to have 5 babies. I want to be able to breastfeed my baby. I want the best chance of it not going to NICU. I want to avoid a traumatic birth. I know I am 38 and my BMI is 29 and, I've had a fracture. What would you, if you were me, or if I were your daughter, sister, what would you advise me to do?
The last thing I wanted to talk to you about was kind of modes of delivery. And you've touched on it a little bit when you're talking about being very clear about how many children you want. What about those women that come in and say, look, I only want 1 baby and I'd like an elective caesarean section because I don't want to risk my perineum if I'm going to just have 1 baby. What's your kind of views on that? Is that, tick, done? Do you...
Oh, yes, tick, done.
Yeah.
All right.
Yeah.
So, again, it's about, childbirth is not there to meet the hopes and aspirations of individual women. It is there, to ensure the survival of the organism, tribe, community, human race. And in a good unit and certainly with an experienced obstetrician, and 1 elective C-section is perfect. Yeah. If you only want 1 baby, my caveat would be I would not do that for a 23-year-old. Well, I would, but I would go, just be careful, because you're young, you don't know what's going to happen. You're with Mr. Perfect. We all know Mr. Perfect turns into Mr. Not Quite So Perfect, particularly after you've had a baby. Yeah. And even some older women, I go, you just have to be careful. Yeah. You're not going to get fed up with them and get a toy boy and need another 2 babies. Yeah. 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 So certainly it's perfect for women in their late 30s, early 40s, career. They've got 1 baby. They want the best baby they can. An elective C-section at 39 weeks is spot on. I hope the obstetrician that told me this, we were at Charlotte's together. I'm not going to mention her name. And she got pregnant in her as an RMO. And I said to her, what are you going to do? And she's like, I'm having a C-section. And I said, why are you doing that? Because she was young. She was 26. She said, well, you know what? Having sex is like having had, it's like having a party in Crystal Palace. And actually, you know what? That is totally not true.
It goes back.
It's totally not true. It does go back. Yeah. You do need pelvic floor, but there is an argument, like, why risk? If you only want 1 baby, there are, and particularly if you're older, where vaginal birth, you could end up with forceps. It's a very reasonable, good solution. Yeah. My thing is always, if it goes against your values, if actually you always thought to feel like a good mother, you needed to push that baby out, don't bypass that.
Yeah, try.
Because other people are saying, what the hell are you doing? You should have a C-section.
Yeah.
Like, if you need to push it out for it to feel aligned with your values, push it out.
Okay.
But if you don't, it's a real get out of jail free.
Yeah. And talking of the pelvic floor, do you feel like the forceps, it's time to retire it? Good instrument or time to, because it is associated with, of all the modes of delivery, you know, natural vaginal delivery, cesarean, elective cesarean, von Toos delivery, it is the mode of delivery that's associated with most pelvic floor dysfunction. I mean, I always used to love doing forceps.
Yeah,
but what do you think? I mean, I've lost count of them times on a birth plan. I see no forceps. Yeah. Lots of people don't want it. Lots of people are scared.
You know, and I think that's right.
Yeah.
And if you really don't want forceps and you're only having 3 babies, have a cesarean. You know, particularly if you're high risk, because very occasionally it is too dangerous to do at the very latter half of labour.
Yeah.
To do a C-section.
Yeah. Rather
than a forceps. There are like most things, it's not the tool, it's who's using it. And I think by the time people get to private, particularly obstetricians who've been through the NHS mill, they are able to safely judge forceps when it is the right time. It is the right tool for the right time, and we shouldn't take it away.
Yeah.
But I think the use of particularly rotational forceps and what we call mid-difficult forceps, we should not be using them.
Yeah.
If we can predict them and we can avoid them.
Yeah.
In the NHS, things happen and you sometimes can't take the steps. So what I would do in private is the labour would have been going on and on and on. We're kind of nearly there, but you can be pretty sure the only outcome of this is going to be an assisted delivery and possibly a difficult forceps.
Yeah.
And I would just say to women, we can go on for another 3 hours, but my gut feeling here is we're just going to end up with a forceps. Is that what you want?
Yes.
Or would you like us to do, before it gets too late, to do a section, which will be much safer if we do it now?
Yes.
Rather than waiting to be absolutely certain that we couldn't do it vaginally. And most women are sensible. They go, I really don't want a difficult forceps. And as an obstetrician, I really don't want a good forceps. Even though I'm really good at them and I quite enjoy them, I know that woman's, it's not going to make her day.
Yeah, yeah.
We don't quite have that in the NHS. And the good thing is obstetricians now are very, very good with von Toos. So the chances of you ending up with a difficult forceps is quite small.
Yeah.
And I would always say, don't say I never want a forceps, but say, if it's clear that's where I'm going to end up, I would like us to bail out.
Great advice. Yeah.
And I only want a forceps if we absolutely couldn't foresee that, and it has to be done to save the baby.
Okay. Yeah.
And it just be clear about what you want.
Yeah.
I mean, it's again a bit A-level obstetrics, but you can start to submit a birth plan, which your obstetricians and midwives will engage with because it makes sense to them.
Exactly.
As opposed to Evian, San Pellegrino, which they're just going to ignore.
Exactly.
Or they're just going to go, oh, this is another person who's no clue what birth is really like.
Exactly. And that's, that's kind of the point of this episode, is that, no, don't expect women to have a PhD in obstetrics, but there are lots of very clever women out there who are very capable of understanding these concepts. And if we only give them that a bit of knowledge, they can make those decisions.
Yeah, give them the tools.
Exactly.
Every woman should be able to engage with their system after this podcast in a way, even if it's just the O-level version.
Yeah.
And
that's all it needs.
Yeah, be clear. I want a healthy baby.
Yeah.
I want the healthiest. If my baby was going to go to Cambridge, before it delivered.
Yeah.
I want it to go to Cambridge after it delivered.
Absolutely. Yeah.
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 And that's all you need to say.
Absolutely. And I think if you give women those information to be able to empower them to make those types of decisions, the ones that really matter, then you are going to get less of the lights must be on or this music must be playing. Yes, you'll get that as well. But I think the emphasis that women put on those smaller aspects might therefore kind of wane in significance.
Yeah, and you're also going to reduce this constant thing of trauma in the system.
Exactly.
Because if you have given clear instructions to your service provider about what you want, and that includes, I don't want a baby that dies, I don't want a baby that's brain damaged, I want it, you relatively have a clear conscience on whatever happens, and you will navigate the trauma better than someone who's gone, I want a water birth, I want a home birth, if it's inappropriate. Yeah. So your outcomes are fundamentally all of that, but most importantly, that you navigate, if the typhoon hits, you have bolted your windows closed. Yeah.
I wanted to talk a little bit about some postnatal choices, but I don't think we're going to get time for that. But I thought I'd just show you a little fun video.
Okay, show me the fun video.
Now, I thought the most snake oil thing I'd seen in healthcare was eating your placenta. But I found something more.
Can I talk about eating your placenta?
Tell us about eating your placenta.
Don't eat your placenta.
Thank you.
Yeah. Animals eat their placenta so that they won't be picked off by predators.
Yes.
That is not a problem in Marylebone.
Thank you. Thank you. So I thought that was like the most how do you make money out of absolute nonsense?
Yeah.
But no, this is it.
Both of my children are Lotus birth babies. What is a Lotus birth? A Lotus birth is when the placenta and umbilical cord remain attached to the baby. It dries up over the course of 3 to 10 days, and it eventually falls off naturally. This allows for a more gentle, less invasive transition from the womb to the world. Almost 1/3 of the baby's blood remains in the placenta after they're born. That is why it is crucial not to cut the cord immediately after birth and allow their blood to pump back into them.
Yeah, no, so
Let's talk about this.
Absolute classic.
Yeah.
And fully understandable.
Yeah.
I am confused. Yeah. I don't trust the system.
Yeah.
I need a narrative that is my magic bullet. This is my rearranging the deck chairs on the Titanic. This is the reason that I may be going down, but I've got something to hang on to.
Yeah.
It's a complete crock of shit and super dangerous.
Isn't it?
Super dangerous.
Oh.
So placentas come out, and if you swab them, 90% of them are infected. And it's not just...
There was actually a baby who died.
But there would be. And I had quite a lot of patients who wanted to do this. And unlike most things that I would go, I'm fine with it, I absolutely was a no.
Yeah.
We always did delayed cord clamping. There's really good evidence for it.
And that's pretty standard
and
now,
it's standard. It's very important for preemies.
Yeah.
It's good for term babies.
Yeah.
And you can nearly always do it, and it's perfectly fine. The Lotus birth is just...
pseudoscience.
It's complete, yes. It's dangerous, really dangerous pseudoscience.
Yeah.
So group B strep, we know, is very dangerous, but it's not the only bacteria that hangs around in the vagina. You're hoping you have a lovely microbiome in your vagina that's going to help the baby, avoid all sorts of things.
Yeah.
But unfortunately, not all of us have a wonderful microbiome. Some of us have, pathogenic E. coli, all sorts of bacteroides, some very nasty anaerobes, group B strep, group A, it is not, like most things, it's not a magic bullet.
Absolutely.
And actually, the Lotus birth is a magic bullet that might just kill your baby.
Right. Good.
Don't Do it.
Thank you. I'm glad. When I saw that video yesterday, I was like, I have to show this to Lucy.
I can't believe that's the first time you've come across the Lotus birth.
I've never seen it. And
oh
also,
God, that's been going on for about 10 years.
The herbs that you use to make sure it doesn't smell. I mean, gosh, what snake oil is that?
If it's smelling, it's
decomposing.
It's decomposing and
no longer serves a
right
purpose.
next to your baby.
Exactly. It's just
and
madness.
Also, what a fantastic waste of your mothering time.
Right. When carrying around that thing.
Yeah. God. Oh, sorry.
No, don't do it.
No,
please don't do it.
Don't do it.
Okay, so thank you for that, Lucy. So now we actually know each other because I worked for Lucy in Central Health Hong Kong, which was brilliant a couple of years ago. And obviously now you're here doing the same thing. So what was that transition like? You've gone from running your clinic in Hong Kong and doing 6,000 deliveries there over the time that you were there. And now you're starting again. You told me you were retiring. What happened?
So I was retiring, and I didn't ever expect to run my own clinic in Hong Kong. And as I explained, I got accidentally pregnant and then accidentally, because I didn't get maternity leave, ended up in private practice. And I ended up running a private practice, not like most private practices. So we were very women focused. So in Hong Kong, we employ about 120 people. We see 2,000 patients-ish a week. So it ended up this really big thing, but it started off just women and children.
Right.
And I like working with women, and I didn't think we'd even have men anywhere near the practice. Sorry, but I've got a few men there. So we employ 120 people in Hong Kong, and like 110 of them are women.
Yeah.
And it was just it was very female centric.
Yeah.
So
it's a very fun place to work.
It was, and it was run on female values.
Mm-hmm.
And so I loved it. And leaving it was it was like leaving a baby behind.
I can imagine.
But I thought, enough's enough. I'll be fine. I'll go and do my day in the NHS for free, doing a cesarean section list, and then I'll spend my time shopping and, going on holiday. And I think the thing that shocked me was how broken the NHS was.
Yeah.
And how sorry I felt for everyone trying to do their best in it.
Yeah.
And really no single organisational fault, other than probably government not having the guts to call it.
Mm-hmm.
But I realised that if I did one day a week in the NHS, I would need somewhere to recover from my one day a week in the NHS.
Yep.
And so I decided to set up a copy of Central Health Hong Kong in Central Health London.
Amazing.
And actually it's been a challenge, but it obviously once you've done it once, it's easier to do it again. Having said that, it's more difficult to do it from scratch. Yes. But what works because you've made all the mistakes somewhere else.
Yeah.
And you want two things for the obstetrics, which is the most important thing to me, which is that you have the people who are really, really good at obstetrics, but you also have systems in place, because no single-handed private practice, in my view, in obstetrics is dangerous because you don't work as a team.
Yes.
So you're really trying to create all the positive things that are in the NHS.
Yeah.
The teamwork, the great midwives, but a single person responsible to the patient for their outcome.
Yeah.
So a named obstetrician that absolutely they promise to get it right for you.
Yeah.
And the clinic itself provides all the support.
Yeah.
And the second thing I've always thought was incredibly important is to treat mental health alongside physical health. So we do obstetrics, pediatrics, psychiatry, psychology, general practice. Did I say that? I've got But basically, you're a one-stop shop. And if you've got a complicated care, we do it all in one place.
Amazing.
And we're very, very nice to our staff.
Yeah, you are. You are. And it's beautiful. And it's somewhere you'll be happy to spend.
Exactly. But you want to create the environment where people feel, if staff are happy, they have the capacity for the compassion and empathy that anxious pregnant people need.
Yeah.
And that's what we created in Hong Kong. And that's what we're creating in London. And yeah, it's been a lot more work than I expected, but equally quite a lot of fun.
But fun. Yeah, amazing. Right. Well, thank you so much for coming in, Lucy. It's been absolutely brilliant. Such a great conversation. I think we probably could have gone on for another couple of hours. But do you have any other kind of take-home messages for women listening?
Just use your head. Don't get confused with my heart and my body. Understand what your emotional side needs.
Yeah.
But use your head to navigate the system. Do your research. You don't need a PhD in obstetrics, but you do need to have very clear communication about what's important to you. And you need to don't assume things are a given, and don't let people guess. Be clear.
All right. Well, thank you very much. And that's it from me. I've been Dr. Natalie Hutchins for the Women's Handbook Podcast.
The content of this podcast is for educational purposes only. It is not intended to replace the doctor-patient relationship, nor does it constitute personalised medical advice. If you are affected by any of the topics discussed, please speak to your doctor or a qualified healthcare professional.